let's talk about one of the most intense environments in all of medicine, the critical care unit. This is a place where everything happens fast, the stakes are unbelievably high, and the tech is just as complex as the patients. All right, let's get into it. And that is not an exaggeration, not at all. Every single tweak on a machine, every word that passes between team members, it can have massive, immediate consequences. We're talking about taking care of patients on mechanical ventilators, and that is a true balancing act between hard science and human teamwork. So, our game plan today is to break down the three big pillars of mastering this world. First, we're going to learn how to spot a disaster that's moving at 100 miles an hour. Second, we'll get under the hood of the ventilator itself. And third, we'll look at the communication tools that stop catastrophic mistakes when the pressure is on. Okay, let's start with pretty much the scariest, most acute emergency you can run into with a ventilated patient. Attention pneumothorax. This is a nightmare scenario where the very machine that's supposed to be helping the patient breathe can, paradoxically, make things so much worse in just a matter of minutes. So what's really going on here? Well, at its heart, it's a one-way valve problem. Air is leaking into the space between the lung and the chest wall, but it can't get back out. And with every single breath the ventilator pushes in, more air gets pumped into that trapped space. It's literally like blowing up a balloon inside someone's chest that just keeps getting bigger and bigger. And this whole process sets off this awful, deadly chain reaction. As that pressure builds up, it doesn't just collapse the lung on one side. No, it physically shoves the heart, the major blood vessels, and your windpipe, the trachea, all the way over to the other side of the chest. This incredible pressure then clamps down on the big veins so blood can't get back to the heart. Cardiac output just crashes, blood pressure plummets, and you are in a death spiral. Being able to spot this at the bedside without waiting for an X-ray is absolutely everything. The early clues: a super fast heart rate, the patient is suddenly struggling to breathe, and when you listen with a stethoscope, the breath sounds on one side are really quiet or maybe just gone. But if you miss those, you get the late textbook signs. The neck veins are bulging out, blood pressure is catastrophically low, and you can actually see the trachea being pushed to one side. If you see that, you are literally seconds away from a full-blown cardiac arrest. So here's the bottom line. You cannot wait. You have to act. The first, most immediate step is needle decompression. You stick a large needle right into the chest, and you'll hear this hiss of trapped air escaping, instantly relieving that pressure. That buys you time to get a chest tube in for continuous drainage, and you crank the oxygen up to 100% to get as much as you can into what's left of the working lung. Now, this all sounds like a diagnosis you make with your eyes and ears, right? But what about the machine itself? Can the ventilator give us a heads up that this is all starting to happen?
Yes, it absolutely can. You have to be watching the ventilator's pressure readings, specifically something called the peak inspiratory pressure, or PIP. If you see that number suddenly shoot up and stay high, the machine is telling you, hey, I'm having to work way harder to push this air in. That could be your very first clue that pressure is building up where it shouldn't be, long before that patient's blood pressure even starts to drop.
And that brings us perfectly from the crisis to the machine at the center of it all. The ventilator is an amazing life support device, but managing it correctly is a constant, delicate balancing act. When you boil it all down, you're really juggling four main settings. You've got tidal volume, that's the size of each breath, and the respiratory rate, which is just how many breaths per minute. VO2 is how much oxygen you're delivering. And then there's PEEP. And PEEP is where a lot of the magic and the trouble really lies. So what is PEEP? Well, it stands for positive end expiratory pressure. But what it does is way more important. Think of it as a little bit of constant pressure that keeps the tiniest air sacs in the lungs, the alveoli, propped open, even after you breathe out. Its main job is to stop them from collapsing shut between breaths.
And this really shows you the tightrope you're walking with PEEP. On the one hand, keeping those little air sacs open is fantastic for oxygenation. You're creating way more surface area for oxygen to get into the blood. But on the other hand, all that constant pressure inside the chest can start to squeeze the heart and the big blood vessels. That can actually reduce the amount of blood returning to the heart, which can cause blood pressure to drop. See the problem?
So, with all these tricky trade-offs, how on earth do you know if you're getting it right? The answer is the arterial blood gas, the ABG. Think of it as the ventilator's report card. It's a lab test that tells you exactly how well the lungs and the machine are actually doing their jobs. You can really break the ventilator's job down into two simple goals. If your mission is to get the patient's oxygen level up, the PO2, your two main fools on that ventilator are going to be the FiO2 and the PEEP. Now, on the flip side, if your goal is all about ventilation, and by that I mean blowing off carbon dioxide, the PCO2, then your go-to tools are the respiratory rate and the tidal volume. Those two control how much air moves in and out every minute, which directly affects how much CO2 gets cleared out. So this is your cheat sheet. This is what normal looks like. You're aiming for a pH in that super tight range, a PCO2 somewhere between 35 and 45, and a PO2 ideally up above 80. Every single change you make on that ventilator is just an attempt to gently nudge these numbers back where they belong. But here's the thing, all of this amazing technical knowledge, it means absolutely nothing if the team can't communicate effectively. When things are moving fast and your brain is overloaded, standardized communication isn't just a nice idea, it's a non-negotiable safety net. One of the best tools for this is called SBAR. It's a simple framework that forces you to get straight to the point. Situation: Dr. Jones, this is Sarah. Mr. Smith's blood pressure just dropped to 80/40. Background: he's 1 day post-op from his big surgery. Assessment: I think he's getting septic. Recommendation: I need you to come to the bedside now. In the meantime, should I start a fluid bolus? See? It's clear, it's fast, and it's actionable. Another fantastic tool is CUS. This gives anyone on the team, I don't care if you're the senior physician or the brand new nurse, a way to raise an alarm. You start with, I am concerned about this plan. If that doesn't get a response, you escalate. I am uncomfortable moving forward. And the final level, the one that stops the line, this is a safety issue. That phrase should bring everything to a halt so the team can reassess. It cuts right through hierarchy. And it doesn't stop there. Other powerful habits include things like checkbacks. That just means repeating an order back out loud. Okay, so you want 10 milligrams of morphine? To make sure you heard it right. It's called closed-loop communication, and it prevents so many errors. Then there's the two-challenge rule, which says you can voice a concern a second time if you feel like you were ignored. And after that, you're empowered to go up the chain of command. These aren't just bureaucratic rules. They are life-saving tools for a great team. So as we bring all this together, what's the big takeaway? We've talked about a crisis, we've talked about the machine, we've talked about the team. So what's the common thread that ties it all together? It really comes down to this. Real mastery in this world depends on two things equally. You have to have a deep nerd-level understanding of the machine and the physiology. But just as important, you have to have rock-solid standardized protocols for how the humans talk to each other. One is totally useless without the other. And that leaves us with this final thought. Clinicians are walking this tightrope every single day, finding that perfect balance with pressure, just enough to help, but not so much that you start to cause harm. Navigating that razor's edge, well, that is the entire game when it comes to managing mechanical ventilation.